So I'm going to touch on these 5 different types of humanistic psychotherapy. So we have the positive psychology movement, we have motivational interviewing, we have existential psychotherapy, Gestalt therapy, and emotion-focused therapy. So the positive psychology movement really emphasizes human strengths rather than pathology. And the goal is to cultivate happiness in addition to reducing symptoms in psychotherapy. So a lot of times in traditional psychotherapy, the focus is really on let's take care of these anxiety symptoms, let's help you recover from your trauma response, and less so about really building on strengths. And so in this positive psychology movement, they really emphasize the importance of focusing on all 4 of these areas of a client's life. So the weaknesses and undermining characteristics within the person, as well as the strengths and assets within the person. And then they also focus on the destructive factors and resources that are lacking in the environment, as well as resources and opportunities in the environment. And so in positive psychology, they've kind of identified 7 categories of positive psychology techniques. I know this is kind of broad and we don't unfortunately have time to go into more detail, but it's helpful just to get an idea of some of the things that a positive psychologist might work on. So things like savoring, which is really focusing on joyful moments in kind of a mindful way. Gratitude, so showing appreciation. Kindness, empathy, optimism, encouraging strength-based activities, so applying personal strengths to somebody's like behaviors or activities that they do, and meaning, so really exploring the meaning that people find in life and helping identify goals related to that meaning. And so positive psychology, it's not necessarily a set of strategies, but it's really this kind of shift in focus. It really emphasizes that we don't have to necessarily focus on mental illness. We can focus on mental health. And so I like this little chart. It just kind of shows that, like, a lot of times in traditional psychology, we are looking at comparing people who are mentally unwell to like kind of the average level of functioning. The positive psychology is kind of looking at like, what about people who are flourishing? And we really need to kind of like expand the spectrum and really understand not just what makes people, have mental illness, but also what helps people, have positive mental health. And these positive interventions and kind of this strengths-based approach can really be blended into other forms of therapy. So just a sneak peek, we'll be returning to this in chapter 15. My personal favorite type of therapy to do is acceptance and commitment therapy. And this is really solidly within the positive psychology movement. It has a big emphasis on values and exploring kind of the self and meaning and how that can tie to then having like very specific behavioral goals. One of the big benefits of positive psychology is that clients might also just be more likely to engage. So they might find it more acceptable than other types. If you're not just saying like, I need to fix you because you're broken, but instead you're saying like, what are all the kind of cool things you can do? That is going to be kind of a much more enjoyable experience for the client, and it might lead to better engagement. So I want you to just think to yourself, or you can comment, who do you think positive psychology might be most effective for? So then I want to spend a little bit more time on motivational interviewing. I know this is still kind of like an intro class, so we don't go into a lot of like specific clinical skills, but I do want to spend a little more time on motivational interviewing because I think it is something that you guys can learn. And it's actually really useful across settings. Like you can use it if you're having like a difficult conversation with friends or family. If you're going into kind of like any sort of like helping profession, it doesn't have to be psychotherapy. A lot of people use these strategies. And it really is a revised application of the basic humanistic principles that Carl Rogers originated. So motivational interviewing was originally developed to treat addictive behaviors such as substance use. But nowadays it's used, like I said, across a lot of different settings, and it's often used to augment other kinds of therapy. And it's really focused on helping clients consider their commitment to change. That is really the ultimate goal. So it's a very client-centered approach, non-judgmental. It attempts to address the client's feelings of ambivalence. And so ambivalence meaning that, you might be weighing the pros and cons of a decision, but you're kind of just stuck in the middle. You're not sure which way to go. And motivational interviewing is different than traditional humanistic approaches. So Carl Rogers' approach, which you can see in a video that I've posted to perusal, is very, very non-directive. But motivational interviewing is more directive. It's not trying to push the clients to make a particular choice, but it's encouraging the process of making a choice. It's helping the clients get out of that kind of state of ambivalence, which, it can be a really difficult, stressful place to be in. You're kind of stuck in limbo when you're having ambivalence about a decision. So I want to revisit, in a previous chapter, we discussed the stages of change model. So this included pre-contemplation, where someone has no intention to change, contemplation, where they're aware that the problem exists, but they're not committed to change, preparation, action, and maintenance. And I want you to think for a moment, where might motivational interviewing be most effective? Where is there likely to be the most amount of ambivalence? I think motivational interviewing can be used in a lot of different stages, but the most common place it's used is the contemplation stage. So somebody might be aware that they have a problem, but they're not committed to change yet. So somebody might recognize that their drinking is unhealthy for them, or that it's kind of causing them some problems, but they still want to focus on their social relationships. So they're still wanting to party frequently. That's going to be somebody in the contemplation stage. They're not quite ready to commit to going sober. So the 4 basic principles of motivational interviewing, we have express, develop, role, and support. So express refers to expressing empathy. You really want to empathize with the person that they're kind of stuck in this ambivalence. You're then developing discrepancy between the two things they're weighing. You're going to roll with resistance. That means if the client is going to come up with, arguments on either side, you're just going to kind of roll with it. And your ultimate goal is to support self-efficacy. So we'll talk about these a little bit more. So expressing empathy is step 1. And this is really important because acceptance is really what facilitates change. If you tell someone that they need to change, sometimes we call that mom therapy, because you can think about when your mom, growing up, or your caregiver was just kind of you need to get good grades, or you need to clean your room. What do you think you want to do when you're told that? You're probably not necessarily going to want to do that. And really, from a therapist perspective, accepting the client where they're at is going to help promote change. And so this kind of reflective listening is really important during this step, and really empathizing with the idea that ambivalence is normal. It is very common for humans to experience ambivalence. We all have to make dozens of decisions every single day, whether it's just what you're going to eat, what you're going to wear, when you're going to do your schoolwork. And having ambivalence about these decisions is very normal. And so the goal here is to accept and understand the client's perspective without agreeing with it, without endorsing with it, and without arguing with it. And you're not looking at the client as being uniquely pathological or incapable. Rather, you're just seeing that they are stuck through these very understandable psychological processes that we all experience. Next is to develop discrepancy. And so therapists often have this thing we call the writing reflex. So obviously, people who go into psychology typically want to help people. And so we want to, fix people. We want to have people's lives get better. But we need to be mindful of this because it doesn't always work. So if a therapist says, to a client, like, you have a drinking problem and you need to quit, what do you think the client would say? They're probably going to come up with the reasons why they don't need to quit, because there's a tendency for people to defend the other side of the argument when they hear just one side of the picture being emphasized. So instead, we need to be really careful that we're reflecting both sustained talk and change talk. So sustained talk refers to statements that are supporting continuing the problem behavior. And change talk refers to statements that are in the form of changing the problem behavior. So this table can be helpful. You really don't need to know this level of detail for this class, but I just wanted to provide some more kind of hands-on clinical skills because I think this is a really useful area. So this is just an acronym to help kind of remember. And these are just some nice examples. So the example overall is somebody who wants to stop drinking so much soda. And so it shows what change talk would look like and sustained talk would look like when you're having this conversation with someone. So if they're saying, I want to stop drinking so much soda, that would be change talk. If they say, I really enjoy drinking soda and energy drinks, that's sustained talk. We have more examples, like, I think I could probably drink less soda and more water versus I can't imagine not having my daily soda, and so on. And so this is one of the very key active parts of motivational interviewing, is really listening for the change versus sustained talk. And so the client should be the one kind of presenting these arguments for change. So again, it shouldn't be the therapist kind of preaching to the client that they need to change. It's really this like non-judgmental exploration of the reasons why and why not they should change. This is based in the theory that change is motivated by this kind of discrepancy between the current behavior and the important personal goals and values, which is really related to that idea of congruence with the real self and the ideal self. And this works because people are more persuaded by what they hear themselves say than by what other people tell them. So when motivational interviewing is done well, when it's effective, it's really the client who's giving voices to concerns, reasons to change, self-efficacy, and intentions to change. So the goal is to have the client do most of the talking. Rolling with resistance, again, refers to this idea of you're not arguing for the client to change. You should never be kind of getting into an argument with the client during motivational interviewing. You're really just empathizing with their hesitancy, their mixed feelings. You're really acknowledging that this is difficult. You're inviting them to come up with new perspectives, but you're not forcing them on the client. And again, the client is the primary resource in finding these answers. And if they're resisting a lot, it's a signal that you as the therapist need to kind of respond a little bit differently. And lastly, supporting self-efficacy. So a person's belief in the possibility of change is an important motivator in change. So working on this belief can be, a whole session of therapy before you're even like identifying the change. And in this type of therapy, the responsibility is placed on the client. So the therapist or the counselor is not really responsible for this. They're just here to help support. And so we're not trying to say, I will change you. I like this way it's worded. The therapist's approach is way more, if you wish, I can help you change. But it's really the client's choice whether they want to change or not. And so the key ingredients to motivational interviewing, much like Carl Rogers' therapy, is reflection. And the essence of reflection is really just making a guess as to what the speaker means. So you're not reflecting exactly the content of their story. You're kind of making a guess at what they mean to kind of push it a little bit further. Reflection can be used in a very directive way, because the therapist is kind of deciding what to reflect and what to ignore, what to emphasize, which words to use. This takes a lot of practice, but it's a really useful skill to have. And these quotes are from this book, Miller and Rolnick, 2002, which is a really helpful book about motivational interviewing. So let's get into some specific examples, which will be helpful to kind of illustrate and give you some like wordage to use. So we have simple reflections, amplified reflections, and double-sided reflections. And we're going to go through this example. So we're going to have a therapist who's working with a client who's in the process of recovering from anorexia. So let's say they've been working together for a while. Through their work together, the client is now eating regular meals. She's gained some weight. She's at a healthy weight for her height, but she's still struggling with thoughts of wanting to restrict her eating again. And so we'll go through some examples. So let's say the client says, I just want to go back to 95 pounds. I felt much better when I weighed that. So the therapist could do some simple reflections. They could say, for you, 95 seems like an appealing goal weight, or weighing 95 pounds would feel more satisfactory to you. This is really, the goal here is to help the client kind of hear their own words, hear their own like meaning of what they're thinking. For amplified reflections, the goal is to kind of intentionally overstate or understate the client's thoughts in order to kind of challenge them to react in a way. And so if the client says, I just want to go back to 95 pounds, I felt much better when I weighed that, the therapist could say, losing weight seems like one of the most important goals you hope to accomplish right now. Or you were happy when you were at that weight before. And I want you to think about, so when might you choose to purposefully overstate what the client is saying versus purposely understate? So you're going to overstate something if you want them to back off of an opening statement. And you're going to understate something if you want them to keep going. This kind of goes to that idea that the client is likely going to kind of have this instinct to kind of defend their position. And so if you kind of exaggerate what they're saying in one direction, they're going to start coming up with reasons why it's the other direction. And this is a really useful tool for helping the client start to kind of build the case on both sides of the ambivalence. So for example, we'll say turning it up. So let's say the client says, it's frustrating when my mom tells me how to raise my kids and keep my house. Turning it up would be, so it really infuriates you when your mother orders you around. And it's likely the client might say something like, no, I wouldn't say it infuriates me. I mean, she's my mom and I know she only means the best. So kind of by amplifying it, by turning it up, you're kind of encouraging them to turn their original statement down. For turning it down, so we can have the client say the same thing. You know, it's frustrating when my mom tells me how to raise my kids and keep my house. And the therapist might say, so it's a bit annoying when your mom tells you you should handle things. So here you're turning it down, you're playing it down a bit. And so it's likely that the client will say, yeah, it does bother me because it makes me feel like I'm still an incompetent kid. And so you can see how this can be a really useful tool to have to help guide the conversation. If you feel like the client is really only focusing on one side of the issue, you can really like push that side, and then they might start to kind of counter argument against it. Then we can also have double-sided reflections. And this is really helpful for summarizing things for the client. So you're saying both, you know, on one hand, X, and on the other hand, Y. So going back to our anorexia example, so if the client says, I just want to go back down to 95 pounds, I felt much better when I weighed that, the therapist might say something like, you've said everything wasn't perfect at that weight, yet in some ways it did feel better to you. Or you'd love to go back down to 95, even though that might mean you'd end up in the hospital again, which I know was a bad experience for you. So you're highlighting how the client is having this ambivalence. They are having both sides of the issue. So this could go on for quite a while, as you could imagine. These could be conversations that happen over multiple sessions. And so, you know, reflection is really helping the client work through their thoughts on the issue. And like I said, this can be a really useful skill to try with friends. You know, You might be already doing some of this without kind of explicitly realizing it. Like if a friend calls and they're like struggling with a decision, you might be kind of helping them look at both sides of the issue by using some of these strategies already. And so after the therapist has these conversations with the client, the therapist is going to kind of hand it back to the client, which is the goal is to show them the big picture. And so here is where we might do things like summarizing the overall arguments. This could even include like functional questions, like what are the consequences of choosing this path versus this path? It could include pros and cons lists. And it's really emphasizing that it's the client's choice. It is they have the power to choose what they want to do. And this is a really nice place to involve the client in treatment planning. So this might be kind of the first stage of treatment when the client is even still deciding whether they want treatment. And while they're kind of deciding this, if they do decide they want to change, then this really segues nicely into treatment planning. So that is motivational interviewing. I hope it was useful to get that level of detail. And I encourage you to try it out a little bit with some of these reflective statements. So then I'm just going to touch on a few more types of humanistic psychotherapy. So we have existential psychotherapy, which is really kind of a unique therapy. I feel like it doesn't relate as much to other types of therapies, but it again can be a cross-cutting type of psychotherapy that can blend really nicely with cognitive therapy, with behavioral therapy. And the overall assumption of existential psychotherapy is that every person is essentially alone, and realizing this fact can overwhelm us with anxiety. And so it's really hitting on some of these existential issues around purpose in life, around connection, around death. And the therapist is really placing a big emphasis on the client's abilities to create their own meaning through the decisions they make. So therapists are encouraging clients to make choices that are true to themselves in the present and the future. And this works quite well for some clients, especially those who are physically ill. So existential psychotherapy is often used with terminally ill patients. Or patients who are kind of preoccupied or concerned with the meaning of life. And again, it doesn't have to be like a standalone type of psychotherapy. It can be blended in with other strategies. So then we have Gestalt therapy. This is also quite a unique therapy because it really de-emphasizes the client's past, and it's really, really focused on the present moment. And so this is focusing on mental and physical perceptions, the client's communication, and it has like these 4 main components. So phenomenological method refers to kind of the awareness of the current moment. So like literally like on a second by second basis, is the client like aware of what's going on in their mind, in their body, in the room. Another component is the dialogical relationship, which fits in nicely with Carl Rogers' approach. This is really having the therapist truly engage as a supportive presence for the client. There are field theoretical strategies, and this is kind of a unique part of Gestalt. So this is really looking at the components and the whole picture, kind of both at the same time. So looking at patterns in the client's life and then trying to kind of map it onto a larger picture. And then experimental freedom. And in some ways, this resembles behavioral therapy, but it's really like in the session, just kind of practicing, like, what if you respond this way? What if you respond a different way? And really just letting it be kind of like this experiment for how the client might respond in like an interpersonal interaction, for example. And then lastly, we'll talk about emotionally focused therapy, also known as EFT. This has gotten quite popular in recent years. It's often used in couples therapy, and it's really focused on encouraging the unfiltered expression of emotion. And the therapist is unconditionally accepting that expression. And so here's kind of the process that EFT is focusing on. It's encouraging awareness of emotions, expression of emotions, the regulation of emotions, allowing the person to make sense of the emotions, and then ultimately transforming their dysfunctional emotions. And this can just kind of keep being repeated. As you can imagine, people are complex and there's always kind of different emotions we can work on our awareness and control over. But this is seen as a humanistic psychotherapy. Some people I've noticed call this a psychodynamic therapy, but it has some components of kind of like becoming aware of the unconscious aspects of emotion. But in our textbook and kind of more broadly, it's also categorized as a humanistic psychotherapy. So that's it for this week. I encourage you to kind of think about the similarities and differences between the psychodynamic and humanistic psychotherapies. And then next week, we'll focus on behavioral therapy and then cognitive therapies.